Good afternoon, everyone. As people are coming into the rounds, I'd like to welcome you to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. I'd like to remind everyone to please enter your questions in the chat at the end of the presentation. And as well, please answer a brief survey that will be made available to you right after the presentation. It will let us know that you were present here today. And finally, it's a great pleasure to introduce our speaker today, known to many of you, Dr.AlanJ Forster. Dr. Forster has been appointed to the McGill Department of Medicine as a professor in innovation. He is also appointed as the Director of Innovation Performance and Quality at the MUHC and the RI. In his roles, Dr. Forster will develop a strategic and operational plan to innovate and improve clinical performance with a focus on transforming and improving quality and safety of care. His previous position was as Executive Vice President and Chief of Innovation and Quality at the Ottawa Hospital. He brings an extensive background as a professor in clinical epidemiology and community medicine, Director of the Ottawa Hospital Center for Patient Safety, and an active physician and social scientist at the University of Ottawa. He completed a research fellowship at the Brigham and Women's Hospital and Harvard Medical School. He has chaired, renewed, and participated as an invited panelist in various committees and conferences related to healthcare quality and safety, artificial intelligence, electronic health information, and privacy, as well as performance metrics, amongst other areas. So today, Dr. Forster is going to speak to us about making an impact and how relevant that is for the Department of Medicine with a focus on MUHC's innovation strategy. Alan, thanks so much for joining us today.
Your phone now, then. Thank you, Nadia. It's a pleasure to be here. I've got a few guests along with me from the Impact Center who are helping implement, and one of them, Camille Lefrancoeur, is going to join me on stage at a moment to do some of a demonstration. So I've been in Montreal now for 2 years. We've just launched something internally that we're calling Impact, the Impact Center. I'll explain what that is. And my goal today, as Nadia said, was to really demonstrate how Impact can help members of the Department of Medicine achieve their goals. And I thought to start that conversation off, I should first say what Impact is. Yeah, Impact was a recognition by our senior leadership at the hospital and the Research Institute that we really needed to work together to achieve success in driving transformation of the health system. And we also needed to create a clear leadership in the area. And to do that, we've created a center of excellence called Impact. It stands for Initiatives and Methods for Partnerships, Analytics, and Clinical Transformation. I'm going to go through those three things: partnerships, analytics, and clinical transformation in a moment. But I would just say, like, fundamentally, what it deals with are specific issues related to those three things that we often have trouble with. When we talk about analytics, it's challenges with the data quality, data availability, our ability to make sense with the data and make decisions. For the clinical transformation, it's building tools that will allow us to support change and then actually being able to afford to buy them and then being able to implement them in our systems in such a way that they benefit clinicians and patients alike. It's not just there to help the patients, it's there also to help the clinicians do their job. And then the third thing around partnerships, again, a big challenge in our system is how do we work with entities outside the institution, whether that be investors and funders of projects or external companies who have technologies that they can bring in and work with us. And so the idea here is that because those are three wicked problems that we have, big problems facing the hospital, and look, they face every hospital. By putting them under a single leadership and addressing them head on, we'll be able to, at least understand the issue so we can start moving towards addressing them in a systematic way together. Um, so, so as I mentioned, better access to data, helping solve problems and supporting change are really the key purpose of why we have impact. I've drawn here a picture, and this is something that we show, quite frankly, like what is the impact center? Well, the impact center is the entire picture there. It's not just the sort of center of the flower. I don't know what that's called actually in the center of a flower. Does anyone know what that is? Like where the petals come out? But that area of the flower, there's clearly a core group that has to understand what the rules are, have access to the data, create the methods that people are going to use, help support the initiatives, the training. But fundamentally, it's not going to succeed unless there's mission-based activity happening. And it could even go further, like it's shown as a mission, but why not be a disease or a health problem? But each of these petals, and the more petals, the better, I would say, but we've got to start somewhere. And so we're starting at the level of the missions. But the idea is that if for us to be successful, there's got to be people, expertise within the missions linked to that central area where they can be they're the people who understand what the technologies that we have available. They're the ones who understand how to get access to data, and they're the ones understand the rules for accessing capital or investments, and those people in those areas are the ones who can then create capacity probably better, like in their mission and in their groups than the central team, because the central team really at best can create common infrastructure, but they don't really understand all the problems, all the issues, all the opportunities. And they don't actually, there's other capital that can be, or other investment, other grants can be attracted into the pedal that allows the pedal to be a bit more autonomous and independent and move things forward in a probably a more, in a more rapid, efficient, effective way. So that's the model, and the idea is that each group will be somewhat will be tied to the center, and will share some of their information with center groups so that we can then make sure that every petal is getting the resources it needs. Because I don't think flowers succeed if there's like half the petals are ripped off. I think and then the arrow on the right represents kind of just a picture to show that there's a top down and bottom up kind of approach where clearly there's strategic direction setting by leaders, and there's also there's no point in setting direction as a leader if people aren't going to follow that strategic direction. But on the flip side, oftentimes it's the front lines, it's the people who are doing the actual work in an institution that understand what the problems. They're the ones, that's where the innovation happens. And so they are feeding upwards to the leadership as to what are the conditions on the ground, how do we be successful? And we recognize that in order for the health system to be successful, in order for MUHC to be successful, in order for the missions or the departments to be successful, there has to be a lot of capacity at that front line. Now that capacity comes with a need to follow the leaders and where we're going. But if you don't give that support to the front line, we're not going to really succeed. So that's what that arrow and it's showing the vine of flowers growing to do that. So because we want to spread like weeds. I thought to get this going in terms of like how can the Impact Center help the DOM. I thought I would just quickly touch base on this, and you probably recite this every morning. Do you have a little class and you have to recite the vision? Like I know at senior Lucio Patterny makes us do it for the hospital vision, but so I just in terms of the I want to read it out because it's interesting. So transforming care locally through effective advocacy, digital innovation, and attracting, training the best and brightest, transforming care globally through world-class translational research teams, providing a safe and healthy learning work environment where we value your growth. I think that's a great vision. And the vision is achieved through the strategic plan, which, and I won't go through all of the 12 enabling objectives or goals, but really, it's around, being the most research intensive, advocating effectively for patient care, being the training center of choice, and loving working here. And I would say, like, really, when I talk about the Impact Center, what I'm trying to do with the Impact Center is help people like you do what that says there. Like that's essentially what we're trying to do with Impact. So I would say there's a full alignment. And I think it's about trying to make sure when you know, in that pedal picture, like who are the people that I'm interacting with that our team is interacting with, so that there is full exploitation of the resources we're making available, and so that the resources reflect what's needed to achieve these goals. And the more we can have that dialogue happening with people who are on the ground figuring things out with us at the center, the more we're going to be successful in moving these objectives forward together. Now, I wanted to show that because I want to show you the next one, which is the MUHC. And it's in French, but I'll just say the MUHC envisions a local to global impact through sustainable and innovative practices, world-class complex care, cutting-edge research, and excellent teaching and learning, all while promoting compassion and a healthier planet. So I wonder, did Dr. O'Patterney commission Dr. Roger to write the strategy, or was it done in reverse? Did Dr. Roger steal Dr. Feller's vision? But I think the point is that they're very similar. Like they're the same vision. And you know, in terms of the strategic areas of work, the only one that's different, really, I would just say, is the issue about the sustainability of the planet. Like, if you look at offering world-class care with inclusive patient experience, or if we look at mobilizing our people, you know, through learning and accomplishment, if we talk about using data to drive decisions, if we talk about transforming through practice, our practice through teaching and discovery, they're all the same. It's the same pillars, basically. So we should be fully aligned in our work. Like we shouldn't be in competition. We should be really working this through. So I would just say, like, fundamentally, the organization's aligned. If I make an impact center, if we collectively make an impact center, and we work collaboratively with you guys to help you with your goals, in many ways, we're helping the hospital achieve its goals. So I would just say, fundamentally, if we start at that level of the strategic goals and the vision, we're 100% aligned. And what we need to do now is work through, like, okay, well, we're doing this here together. How are we? Is it working? Are we getting the results we want? And how do we readjust? We want to go to the same place. How do we, like, are we getting there? And that to me is fundamentally, and the last part I'll just say on that before I get into it is, essentially, that's why we have the impact centers, to help foster the collaboration and relationships that allow us to build the infrastructure and the processes and the business approaches for achieving the goals that we both have, that we share. I think that's a really important thing, that we share the goals, like, and to be clear about that, we do. So if we share the goals, we might have differences of how we get there, but those can be resolved if we share the goals. There is a leadership team to impact, and I'll just mention some of the names here. So myself, Keith Woolrich from IT, David Buckridge, Jake Barrelett from the Department of Surgery, Azadine from our Chief Procurement Office, and Genevieve Dufresne from our finance office. There's a number of members here in terms of helping support. Luma's in the room here. Our data and analytics, Mona and John are running that. Camille Lefrancoeur is here to say she's going to present. She works for Mona, Matthias is here, who's helping with one of the projects in our innovation lab program. So, as I said, three big ways of helping: data and analytics. Okay, the first, and I just want to show you a little bit about one of the things we've been working on to help people understand why there's some challenges in what we do in terms of data. You know, if you look at the far left, this is where we do our clinical work. That's like in the platforms that support clinical processes, clinical applications in the hospital. There's also there's probably over 35 of these applications supporting work in the MUHC. Now, that in itself causes problems clinically. I know you've got to talk to different systems, you've got to organize, and so that's a clinical problem. But in terms of an analytics and being a very, like, progressive world-class center for AI, and we need to have the data integrated and supported and available, we need a central group where the data is connected and linked to each other. And right now we're using a product to help support that called LGI Continuum Core. That's an old technology, and it was built over 10 years ago with data feeds that the institution, the processes were very different between the different campuses in the institution at that time. And some of the legacy of that means that the data sitting here still needs to be reconciled every time we do an analysis. And that may seem, that's getting very deep in the weeds here very quickly. But the idea is that if you're a patient at the MGH and a patient at the same patient, you're going to the Glen, you might be different things in the database. And if we have to kind of we have to, every time we do a study that wants to look at people, we can't have two Alan Forsters or two Abhinav Sharmas. We have to have, there has to be one, it has to be reconciled. And there is processes now going to fix this, but that is a fundamental issue that gets dealt with every day and when we're doing work. Okay, so we have this central data repository. And then to the right of there, we have a bunch of uses. One is their MD Clone. I'm going to show it to you in a moment. MD Clone is a self-serve data application. It allows people to interrogate the data on their own. We have Power BI dashboards, which help us get access to packaged metrics, where someone in a central team helps to organize the data a certain way and then present it a certain way. It's good for showing things that people know what they want to look for, but if someone wants to do data discovery, you can't really use it. There's ad hoc reports where people will say, I want a data set to look at the effect of NSA or the effect of our new unit on NSA length of stay or on our NSA numbers. And then there's a whole bunch of ad hoc programs, research projects, typically where people have to want to combine data. And so this data set here, the data warehouse supports all of these things, okay? Now, if we go back to what I said at the beginning, where in 2015, when they started building this, there was a lot of things that needed to be addressed. Every time someone asks for someone, and we have a very small team at the MUHC responsible for managing the data and these data requests, they have to do that reconciliation. They have to talk to the doctor or the researcher or the administrator and say, what do you need? And they have to interpret it, okay? They have to figure it out. And then that person has to then go into the database and figure out how to do the reconciliation, create the data set that's required. The number of people who want data and the number of uses of data greatly exceed the number of people we have on the team to do that work. Even if our systems were exceptionally efficient and we had great data flow coming in from these 35 systems. So as a strategy, as a hospital, what we did is we built, that's why we brought in MD Clone as a first strategy, because what that does is it allows people like yourselves to access the data directly without having to work with people in between you and the data, okay? Now, it still reflects the data in these 35 systems. It's not like magic. It doesn't all of a sudden tell us the truth, like of what the world is. It tells us what's in the data. So you're going to have to learn what's available in the data and what's not available in the data, and you're going to have to learn how to make a story with the data that you have. Now, I will tell you, there's lots of great information in the data, hugely important. Over time, the data will improve. When we get newer systems, when we get ambient scribes, AI scribes, and we can capture information and it gets automatically coded into diagnosis in a robust, accurate way, and that's happening in all our clinics, all of a sudden that's flowing into MD Clone, okay? So when we get more ubiquitous tracking of vital signs and other health data, boom, it's going to flow into MD Clone. So the idea is that as we build out our data infrastructure to the left, we will also be building out things to the right, okay? And that's a really important thing for people to understand. And the reason why we went to the things on the right first, the MD Clone, is because we believe that, again, going to the sort of philosophy between the Adam Center or the Impact Center is that you guys know what the problems are, you know where the data are, you know how to make value out of the data, get you the data as fast as possible. While that happens, there will be a transformation starting to happen which drives us to push on these things on the left. And whether that be Epic that comes in or new systems that come in or Cerner or whatever system, the stuff on the right is always going to be needed, okay? And so what we're doing now is we're building a capability at this level so that no matter what systems plug in, we have continuity of information to the right. And that means that whatever we do will be future-proof in terms of information management and research. And that's a very critical piece. So I'm going to quickly go now to the MD Clone app, and I'm going to ask Camille to come up because I want to show people how easy it is to do this. I don't know if people have seen MD Clone before. I'm seeing some nods. So what is MD Clone? MD Clone is a big data platform that enables direct access to patient data while protecting patient privacy. What it does is it's probably easier just to show you how it does it. So I've got to go to, oh, you're doing that, Jeff? Look at that. It's magic. I just think it and it happens. Okay, Camille's going to walk us through this. So everyone who logs into MD Clone, you get access to queries or cases. ADAM stands for Ask, Discover, Act, Measure, Share. So when you create a case, you're creating an Ask, Discover, Act, Measure, Share file. She'll show you that in a sec. And what you see on the first page are your cases or the cases that have been shared with you by someone else. So you can work on something collaboratively with a team. Okay, so you can see the first one yesterday, we had Santé Quebec here visiting to look at this. We shared we're going to go through what we showed them. Kemi is the owner of that one. You see the next one, ED visits following surgery. That was me doing that one. The next one is appropriate care in patients who die in the hospital. So we're looking at length of stay, ICU stay, expensive interventions in people who die in the hospital and see what are we learning from that. That was done by our ethicist. So just to show, if you don't have training in epidemiology, and if you don't have training in data science, if you don't have training in health outcomes research or clinical research or informatics, you can still use this platform. I will tell you that if you have training in any of those things, top of your clinical background, you will be that, and it'll be incredibly useful for graduate students or medical students who you want to work with. So let's jump into the Santé Quebec demo. And we'll jump into the synthetic data. So just in terms of the orientation of this is a case. When you start a case, you have to you walk through a description. But to the top left, you see the SQ demo or ask and interact with your data. That's the queries that are supporting this case. Then you have the discover, so you can save your insights in that. So in the ask, you develop your query. In the discover, you store your data set and your visuals that you have for each case. Then once you do your discover, ideally you're going to come up with something where you're going to act. Maybe it's like patients who have elective surgery and have diabetes have a high risk of hospital-acquired infection and therefore have poor outcomes. So we want to improve, and we find that the risk is increased if there's poor glycemic control during the hospitalization. We can then discover, the act might be we're going to ensure appropriate diabetic management in perioperative patients. So the idea is that you come up with a intervention based on your discover that you then put in place, a process improvement, and then using the same query that you generated for the discover, you can then put in place your measurement system. And you don't actually have to go out and collect more data. It's actually being collected through this platform, and then it just becomes a quick turnaround. And I can tell you the guys who did this very effectively at Sheba Medical Center, they turned it into a publishing machine. It was just like literally like both on the descriptive analytics, but also on the intervention side. They're really starting to see major changes on interventions. So we start with this is, I don't want to spend too much time on this because I have some other things I want to show you, but just to show you that the query itself allows point and click. So it starts with something called a cohort reference event, which is really the patients that that meet your inclusion criteria for inclusion into your study. In this case, forgive me, we're going to go after the surgeons a bit. We don't want to go after the internists at the medical grand rounds. If I was at surgery, I would put medicine. Anyway, so we've got like you can really look. So first, so we're including the first surgery, the first encounter, where age is, any age in the year 2024, 2025, at any of our facilities where we do surgery, where it was a short stay acute care, or it was a patient who was an organ donor, and where it was admitted to the surgical department admission. So that, like, now I showed you that, like when you're learning the system, you have to learn how to do these and click it, but ultimately it's not really that hard. You saw that I was able to do this, so it can't be that hard. The next thing you do after you find your cohort, you look for your covariates and your outcomes. In this case, I'll just quickly start with we'll just do hospital-acquired infections. But you see, what we're doing now is we're pre-coding. We meaning the Adams Center team or the Impact Center team. We're pre-coding common comorbidities and common complications, and we're using literature-based definitions. So in this particular case for hospital-acquired infections, we have a condition. Like if you look at this, like conditions is listed as an entity. We said, present on admission equals no. So they didn't have an infection before they came in. And then they had any one of these ICD-10 codes on their discharge abstract. You can see that there's actually 102. They're just showing the 5, but if you wanted to look, you can look. And you can see all of the different ICD-10 codes. Now, as I said, we're pre-packaging this for people, but they can do it themselves. So if you wanted to go, like you can easily search for other diagnoses to add to that list. So you just simply type, and you may not know what the codes are. So again, like if you just type in the word, let's say congestive heart, or no, put in diabetes. So maybe you want to find a diabetes patients. It'll find you the codes for diabetes. You don't have to know what the ICD-10 codes are. And so you can just click. Now, what we recommend, because there's many codes and there's many algorithms, we recommend using published methods for case abstraction. But again, that's when you're getting to the level of research and doing high quality research, which you guys want to do. So the more, and this is kind of a reason why I think having a team internal, like the medical team, to help you do this is going to be very advantageous. Here, we can close that. So what we're going to do now is show you what you're building out a query on your data. And again, it reflects what's in our source systems. Okay. Now, when you create that data, the query we just created has a list of variables that you want to put out in your data. And in the reality, in the data system, what's happening is that there's a data set that's being created virtually. But it's invisible to you. So you've got rows and columns that have patient information hidden in behind the system. Okay. Now administrators can see what's hidden in the system, but you as a user, if you just click next, what happens is it creates a synthetic data file for you on the fly. So right now she's creating a synthetic data file, or the system is creating a synthetic data file. This is completely made up data that you're seeing here, okay? You do not need REB to see this information. You can have access to this information. You can run analysis, and you can see, it looks like data you would pull, okay? It's like if we asked the InfoSonc team to pull this data, it would look the same as this data, okay? Now we've coded good. We've coded a few of these outcomes. So just to look at, we remember we looked at the hospital-acquired infection. We did this analysis before, but just to show, according to our coded data, about 7% of people have a hospital-acquired infection after their admission to surgery. We looked at the impact on length of stay. Here's a box plot we created just to show the association between hospital infection and length of stay. It looks like a 7-fold increase, which seems to be unbelievably big. So we have to understand the data quality on that, or whether there's some confounding that we're not sure about. But if we look at also the return to emergency room, again, here's a 2x2 on whether people come back with the row percentages, and you see that if you have a hospital-acquired infection, you have a 43% chance of coming back out of the emergency room within the next 30 days. So if there's ever an area for improving quality, let's go after hospital-acquired infections. Now, the last thing you can do here is like, so this, we already read the chi-square test. So you can run statistical tests on the fly just to quickly see. Now, clearly that's very much open to confounding, and I just wanted to show you how to do it. But just to say, we also have now the other information in there, just other than what I showed you. So this was just a first glance. Okay, so thank you, Kimmy. And I'm gonna go back to my presentation. Oh, I probably should shut that down too. I'll do that after. So I've got 15 minutes left. I want to quickly go. So that's MD Clone. That has been a big part of our work since the last time I came here, that we were able to get that up and going. These are the data that are now available to do analysis in the check marks. Actually, the yellow medications, I think we're there now, right? Oh, we're not there yet? Still yellow? What's that? Soon. Okay, so we got the labs and we got but the medications are still in yellow. But you see there's a bunch of red ones there coming after, and they're like, there's a process for moving those forward. And again, this is where we need to work very closely with clinical groups, because they're going to help us figure out what we put in. And there's some other features that I'll tell you that I didn't show. There's a natural language processor feature within MD Clone that allows you to create from a text document or a set of text documents. You can turn all of those into coded data, which is then available to do analysis with. So if you have radiology reports or pathology reports or clinic notes, you can quickly turn those into epidemiological worthy data. We have a Teams group, and there was a go live, and I know the Department of Medicine, many clinicians are engaged in this and have been doing it, and I want to thank you for that. And I think we're ready to move forward a bit more. I think when we first went live, we wanted, there's been a kind of rolling launch. We wanted to get an introduction out there and get people ready, but now we're really ready to go. And so if you guys want to join in, let's go for it. There's a couple of last things I'll tell you about MD Clone. One is, there's really 4 areas where we're digging in on MD Clone. The first is operations and quality improvement. So to the extent that that aligns with one of your strategic goals, I think that's an area of that'll create huge value and trust between the hospital and the Department of Medicine. Research is another big purpose, and again, to the extent that we can help support research either at many levels, whether that be applying for grants, publications, training. We've got several courses that we can do, but we've also like to work specifically with you guys if we can make very specific training for residents. I think this would be like a beautiful platform. If you combined like a literature review, systematic review, health technology assessment course with data analytics, health informatics course, and you could do like a 101 kind of level course, and then also combine it with a quality improvement course. And I know Saman is doing some there's great stuff happening in all those 3 areas. So if you combined all that together, as I said, you could become a sort of evidence factory very quickly. Training and education I talked about, and then partnerships with industry is a 4th area. And actually one area where we're trying to go a little bit, I would say not slow, but where we're trying to be cautious is, we're giving people access to data here. We want to get to a point where we're working very closely with industry. In order for that to happen, we need to have a process by which that happens, and we need to have we need to work to ensure fairness with the people with whom we're working, the partners. And so we need to be when you sign on to use MD Clone, we're making you sign a thing to say that you're not sharing it with private partners initially. Okay, so that's an important thing. And then as we go into it, we want to help support the structure of these relationships, because we think it's of huge value to our innovation program, huge value to ultimately the patients, but then if we can create an economic benefit to our institution, that can then be reinvested in some of our IT systems that we struggle with. So that's data. Oh, sorry. Last step. what we're doing now, expanding data and data use, and part of the reason I'm here is because I want you guys to know how to move forward. Introducing some AI tools to help make it even easier than I showed you. So like it kind of like a chat GPT type function overlaid on top of what you see. We're working with a global network of hospitals that have implemented MD Clone. And I think that's really important for this group to understand is like you might have a small cohort at the MUHC, but there might be bigger cohorts in South Africa, let's say, or at Netcare, which is the largest provider in South Africa, or at Albert Einstein, which is the largest provider, is one of the world's best sort of digital hospitals, or at University of Chicago or Manchester. So all of these places are big in their own right and have great capabilities, and they become now places where we can connect and work with them. And then we're working very hard to develop these processes where we can say, okay, you're teaching a course at McGill, here's your data set that you can use, or here's how you can access this for your data. Or we're doing this, oh, you're working with Pfizer and they need data, here's how we set that contract up to make it work for everybody. So those are the things we're working on right now. Okay, partnerships and innovation. So this is something I just want to talk a little bit about this. Sometimes partnerships gets people a bit anxious. Other times people want to move very fast on the partnerships. And partnerships, what I mean by partnerships is working with others to help bring their know-how and help bring their ideas and help bring their capacity to extend our ideas to the globe. You know, to bring those partners in early so that we can then benefit from those things that they bring, okay? Whether it be the opportunity, like their ideas to change or also to reach. And so to be very clear, you know, some of these partnerships could be with private companies, some of them could be with investment vehicles. Sometimes these could be other hospitals in other parts of the world. Some of it could be governments, okay? It could be funders. So the idea is that to support innovation, we need these partners. The problem is that we typically have is that we get into all sorts of problems about like, what is our mission? And are we creating a conflict of interest? And then there's that layer kind of pervades and affects everything. But on top of that, we have like, I would say our processes for creating partnerships and supporting partnerships is very weak within our industry, especially in health, like at the physician level, I'll say, because oftentimes that there's not an understanding of the benefits of creating a strong partnership agreement up front. And also because of the position of physicians where you're privileged, you're not an employee, there's an awkwardness around who has the authority to sign contracts and et cetera, et cetera. So I think it's something that we have, and because the processes are poor, and because there's this overlay of this kind of, I don't know what it is, it's kind of like suspicion that it's not aligned with values, that there's that together those create lots of sort of issues. So we're working on fixing both the perceptual issue, but also the process. Clearly, the process issue is the thing that you can fix the best. So we're working on that. And the way we're doing that is really recognizing that there's two types of innovation that we focus on, right, that exist. And like it's either innovation coming from within or it's innovation coming from outside. And I think that's really important to make the distinction, because if it's coming from within, it's usually in or very early stage, and we need to help people move forward and understand what are the risks when they're moving forward, and understanding the supports they need to overcome those risks. And when it's coming from outside, we have to understand what is the motivation from people from outside to come to us, and what it is that we could get into trouble with. And so there clearly is differences. But to be you know, just to be optimistic, they're very easy to overcome if we work together. So what we've been working with has been a pathway and funding flow. And you know, I will say we're kind of moving this forward in a very stepwise fashion. The initial part of this was getting the governance sorted out. Who needs to be at the table to make these decisions? Who signs the contracts? The second thing is now that we've got that going, we've kind of done this internal soft launch of the Impact Center, being clear on it. And I would say while doing that, we're trying to get some normalization of the processes, like what, like if you're an internal, what do you do? If you're an external, what do you do? And as we're getting to understand what the current state is, we're also now saying, okay, here's how it should be, okay? Because we have a bit more confidence because we've been supporting people along the way to the extent that we can, given the resources we have. So I'll just four Department of Medicine innovators. I put myself in there. Abhinav, I asked beforehand, and Emily, I didn't ask Dr. Tunu if I could put his example there, but I'll just quickly go through these four DOM examples. FrontRx, Abhinav has very innovative guy, lots of great ideas. He's got this great idea now with FrontRx, and I think are you on that committee? Like, is there anyone else here that's in your company? Okay, so it's using ambient intelligence to move from a position where you could essentially walk in a patient room while you're doing rounds, and then walk after and do your assessment, and then walk out. And then, it creates a standard clinical note using a structure that you appreciate, and then you can review and approve it. And then, but the kind of a key differentiator, many of you have seen these kinds of tools, is that it does it in a way that's aligned with your workflow. So it can be inpatient, outpatient. It can generate a patient list with a prioritized to-dos. It can create a fee, like a automatic fee submission, like a reimbursement submission. So there's a bunch of things that are there. And so Abhinav's at this early stage with these great ideas. He's come to us, so he's at that idea phase, okay? Now, what we're doing right now is working with FrontRx and Abhinav to say, how do we structure this so that going forward, we can potentially move this forward so it could be in use for the MUHC. And the idea is what he needs from us is a entity that's going to help him prove out his product so that we can all benefit from it. And what we need to do is figure out what we need to do to help that happen. And then collectively, what do we all get when he makes it big and we can sell it to other hospitals around the world? So that's kind of a story that I think is really important, that there's people like Abhinav in there. And those tools are not, they're like now because of it's not that far-fetched to think that we could get that to happen right now. Emily's story is also quite exciting. She helped support work with Dr. Jensen from the KIN program. They hosted a postdoc in their lab to look at biomarkers for acute phase reactants, but the biomarkers were not in the blood. They were physiological through heart rate detection, and they did an amazing clinical study where they were actually looking at biomarkers and these cardiac responses in people after being randomized to live attenuated virus injection. So they've got a very, very highly predictive set, and that they've now turned that into a company called Sensify, that IP, and now they're working with investors from like Europe and the United States to then now develop a whole bunch of clinical applications for the Sensify. And the idea is it can predict immune hits days before the clinical, like not long after the insult but before the clinical symptoms, and so you can start potentially on therapies. And so the idea is that this has now become a potential product. Francois, so she's come at that right early phase problem, and now she's moved up to a product. Okay, like so she's really moved up to that product. She did that without any help from the hospital, and really sorry, I should say that's not quite right. She did that because of the Research Institute's capabilities to support these clinical trials that were required, and the clinical environment that was required to make that happen. But I would say those were more traditional supports rather than the partnership supports. She herself was able to go out and seek investment from industry to create the funding for that growth of our company. But I can tell you that work has led to like a clinical publication in the Lancet. There's other papers coming out from it. So again, going back to the alignment, I think, Abhinav, you told me you've published work on your large language models too, right? So there is an alignment of this digital transformation with the research agenda as well. Francois did a quality improvement project. Francois Tourneau did a quality improvement project where he looked at the appropriateness of echo ordering and found a large proportion of the echoes on his wait list were inappropriate. So Francois then said, well, what if we could automatically classify these requests into appropriate or inappropriate based on published evidence guidelines? And so now he's working with Ivado Labs. They don't have a product, but together the MUHC and the MUHC doctor are working with a third-party AI supplier to build a product now that could potentially be rolled out to the province because it's pulled off the RI-MUHC data set. So he's building out this methodology now to do that. And so again, very cool idea. But for him, he's really at the idea phase right now still. Myself, I'm working with a company called Luminex, and I'll tell you a little bit about the technology in a minute, but they themselves have what I would say they have a product, they have a solution that's fully cooked, but can be the platform for further development and further problems to be solved. And so we've entered into a relationship with the company where we're helping them develop new applications for their platform. So that's just I wanted to give 4 examples because to a certain extent, it shows A, that there's a lot of action happening, but B, that there's they're solving different problems. They're at different phases of the development and they need different things. So Abhinav and team need a sort of idea about what do we need to grow internally. Emily's needs help to figure out what the clinical applications they've got but they're well financed now and will have the capability of doing that. Francois needs access to our IT systems and figure out how to make the data available to an external company. And I'm working with an external company which is involving redesign of the hospital, and so we need a whole bunch of different teams involved. And so just to say the partnerships are multifaceted. Each people need different things to make the transformations happen. And really what we're doing now is building the capabilities to finance that, to facilitate that, to accelerate it. I'll just go a bit about AIMS because I think it's so important it's a big project, a big transformation project. AIMS is a system for monitoring patients in their rooms using AI. It uses a ceiling mounted node, it's called, and behind this black dome is a camera that sees infrared spectrometry. It doesn't see images like we would see. It sees little dots in space. So this green thing is what it shows. But those little green dots then are interpreted as to being what kind of object are they. And it takes a picture of these dots, this 3D space map, it does it 30 times a second. It takes a picture. So it can actually interpret complex movements in space. And it captures ubiquitously the environment. And then because there's AI at the point of in the node, it can then transmit that information in a privacy aware way. It doesn't have any information on the patient. So it looks like this. It monitors the room, and this has become now a sort of major issue, especially if you notice in this thing that there's a thing here, which means it's also a microphone. So if we have ambient technologies, we can just layer into this where people can now other technologies. So this is an near-infrared scanning, but we can put in sound, we can put in even smell. And there's all sorts of different signals that we can start to tell directly from the platform. The last thing is it's Bluetooth enabled, so if people have wearables, it can connect. And so all of the computing about a patient can be done can be done at the point. and which diminishes the cost of further server utilization, diminishes integration requirements, diminishes risk of privacy, et cetera, et cetera. That's what it looks like. And so we've got out of the box hand hygiene and fall prevention, but the other thing with this relationship is that we've been given this opportunity to build apps as part of our contract and own the IP. So the idea is that if we wanted to integrate a ambient AI scribe into this, it's now the places we can build out that app and we own that app. If we want to build out a seizure detection system, we can do that. If we want to look at a respiratory compromise detection system, we can do that. All of these things are, and I'm really looking to the clinical teams here to reinvent how we do clinical monitoring, because now we can actually get real-time data 24/7, 365. Like we're actually getting data every 0.03 of a second of what's happening in a patient room. That we can then build out. So we may not need to document ever again, is my goal, that we never have to write. So you can imagine walking in a room, you're getting told when you're walking in the room, either on your phone or on your Google Glasses, this is what the patient's problems are, this is what's going on. You do your assessment, you walk out. The same thing pops up now with your note that you approve and it's good. That's not too far away with these kinds of systems. And if we, especially again, if we work together. So that's the aims. There's lots of companies and partners we're working on. I wanted to show you that just some of them. Some of them you'll note are companies that we either started or that are we're working here. Some of these are governments. Some of these are non-governmental organizations, and some are universities. What we're doing now on this is foundations. We need to work on that with them. There's different approaches for funding this. We have to articulate our priorities, create a community practice, and that's one area where I'd like to really work with you guys. Again, going back to the pedal, who are the entrepreneurs? Who are the people who really want to do innovation within the Department of Medicine? We are working centrally on the policy development, and then we have to figure out how we do this with Santé Quebec. There's some real challenges with us right now, in the sense that Santé Quebec is, it's new, and so the question is how do we work in a decentralized way with an organization that wants to be centralized in a way that everyone feels comfortable that we're supporting the vision. The last part of impact is clinical transformation. I don't want to spend too much time on this, but just to say, you obviously know whenever you take something to CASP and you get frustrated, it doesn't happen, that we need a better way of helping these things move forward. And if we're going to have we have shared goals, but they don't often get articulated into shared action. And I think for that to happen, we need these kind of things to happen, like to be really clear priorities, access to data, and how to turn that data into information to support change, a process for review, the actual team that's going to help you support you, and then the evaluation of the impact. And again, the more of this we can push down to the local level, the better we're going to be. And then lastly, training and mentorship is really critical. There's training in so many different areas required for this, but that's why, again, having experts at the local level who feel comfortable training their colleagues, finding those key early champions to help move things forward will make a big difference. So how can you contribute? I think the main thing is to find those people in your department, and you've already got them through formal leadership positions. Dr. Ahmad, for example, Hassan from general medicine, I mean, she's incredible what she's doing right now for developing training and quality improvement. So we got to work with her. I mentioned some of the entrepreneurial type folks and the folks doing innovation. We need to also, from the hospital side, make sure we have the right people around that team of people to say, okay, how are we making sure that they're as successful as they can be? And where there are differences of approach, how do we make sure that we can bring them together to at least articulate the purpose? And then, each mission, and within the mission, structure for quality improvement. We have people who are very fully autonomous in using empty clone, because the more you have to rely on us, the longer it's going to take for you to do anything. And then help us build the tools to support the decisions that have to happen. Support training, and then identifying innovation. So that's the end of my talk. I apologize if I went a bit long, but
Thank you. Thank you so much, Alan. That's terrific, and so happy to see progress in this area. Thanks for spearheading this. Are there any questions? I see some questions in the chat. Yes, okay. Is there a question in the room before I go to the chat? Okay, let's go to the chat. Somebody's asking about, Sasha's asking about Power BI dashboards. Are RI-MUHC working on these, or are they available? Can you talk to us a little bit more about Power BI, please? From a research point of view, it looks like.
Research or
it's unfortunate,
clinical?
Sasha, we can't have a conversation openly. Can you?
Sasha, you can unmute. It might be easier.
Hi, Sasha, and I know we've been trying to get together for coffee, so I apologize. Our calendars don't match up. But just to say, thanks for your question. Maybe I'll just ask you to be more specific. And when you talk about Power BI,
I don't understand the concept. You had it on your slide
oh, I see.
before you started talking about MD clone.
Okay, yeah. So Power BI, it's a you'll see it in the Office 365 suite of applications. So it's like if you look at Excel, Word, PowerPoint, there's also Power BI. And Power BI is a way, and Power BI, the BI stands for business intelligence. And Microsoft made this play a few years ago where, because previously BI tools were like big, massive implementations that very few people understood, and there was a clear understanding that people at the local level needed to control some of this. So what it is you can think of it as if you think of a Excel, Microsoft Excel, and you have certain you can make graphs and figures using Excel. You can think of it as that, but kind of a bit more exciting in that it can be set up in a way that automates the ongoing data that's being brought into it, and then updating the figures that you're seeing. So rather than manually sort of updating your tables and figures, it does it for you as more data comes in. So people use it in business always because you say, I'm looking at the daily number of admissions. And so it's like today it's 12 and tomorrow it's 15 and the next day it's 10. And so you can track it over time. You can set this up. And so if there's a data feed, you can just set it up. So, and the second thing is it's built in a way that makes it easier to look at by different groups. So, normally what you want to do with Power BI is you want to look at, I want to look at the admissions by day of week. Okay. Or I want to look at the admissions by medical by medical division, or I want to look at by campus, or so you figure out these concepts that you want to look at your analysis. But it wouldn't be set up in a way that you would allow you to do an analysis for a study. Like someone has to set it up for you, and typically, like the data feeds it from a certain place. So I would just say, like, ultimately, it's quite useful if you're running a business because you can have a team like Camille to help to set it up for you. And then now you can distribute it to hundreds or thousands of people. But it's actually, to learn it and to get access to the data, it isn't the easiest thing to do. So
Question on empty clone. Sasha, you have a question on empty clone?
Well, Alan, you said this, and I emailed you before about it. Like, I'm so scared of click and point applications because of the problem is that we can so easily get into problems with methodology. Even if you have a PhD in epidemiology, you can still, have biases.
I agree with you 100%. I would just say that's why we rely on people like you helping us do this, because ultimately there's a lot of crappy publishing. You can do that with real data, as you say. Like, so first of all, I don't think anyone's going to publish the synthetic. Very few people will publish synthetic data on its own, unless there's a very good reason to have synthetic data. You know, people are going to want the real data. Now, I showed you up to the point of generating the synthetic data, but I told you also that the real data was sitting there behind that synthetic data. So our intention is you, Sasha, let's say your research team is doing an analysis, you want to figure something out. You can do your own analysis on the synthetic data and you can find something that you think is relevant and important, and you can use your methods to the level that you think are right, okay, to do that using the synthetic data. Once you find the answer once you find something that you want to write about, that you think is, you know, you've addressed your objectives, you've generated the results, and now you want to write it up. It's very easy to get the real data. And the REB, we're setting up a process right now where, you know, it's low risk research, by the way. So the protocol will be very easy to create. The research, the privacy assessment, the EFEP will be very easy to justify. Like, it won't be very difficult to go, and then finally the data is already there. Like, so to go from an analysis of hypothesis generating to a paper is not like, to get the approvals and to get the paper written, it's not going to be a big jump. And that was my point. But then you still rely on you still you know, have to respect the peer review process, and, you know, hopefully it works, you know, like ultimately, you know, I've seen bad stuff published though, like, I'll just say that. Hopefully not mine, but anyway.
We're running low on time. There's just a question about OASIS. Can you use OASIS for research, or is it not a great EMR for research?
So yeah, no, I'm just trying to think of a good answer. So it is what it is, I will just say. Like, so there's certain information in OASIS. Like, if you look at our lab data in OASIS is very good. If you look at the encounter data in OASIS, it's very good. If you look at the things that are in our clinical notes, it's terrible. Okay. So don't look at the clinical, and we're not going to bother bringing in I mean, it's mostly scanned documents. You can't use it anyway. So ultimately, but my feeling is we're going to go away from scanned documents. We're going to go to more digitally created documents. Those digitally created documents are going to then get more accessible to digital tools to translate those using LLMs into coded information, which will then become more accessible and more available and more able. So the answer is, it's great or it's bad. It's like, in times it's very good, at times it's very bad, and you have to know when it's good or bad. That would be my answer to that question.
Alan, I'm going to cut you off. There's another question there. Maybe you could just type it into the chat. Thank you so much. Really terrific. Really great rounds. Very, very interesting. And so happy to see the progress that's happening in this area of innovation and bringing innovation to MUHC. So thank you very much for presenting, and thanks everyone for joining us. Have a great afternoon. Bye-bye.